starting in just a couple of minutes. All right, it's about 5 after, so we should get started. We have a guest speaker, so I'm excited. Can you guys see my screen? Beautiful.
Yes.
The agenda
I see your
today,
screen.
perfect, is just to go over a few things, but I do want to give as much time for our presentation, and then I'll send out the PowerPoint after if needed. The biggest thing today is competencies are due. We had asked that they be done 10 days before, so if you haven't done them, you're a little behind. You may have received an email from me about this, and you'll be receiving another one as we get closer to the deadline. And then we do have another due the annual refresher on October 1st, and then the annual provider training on December 1st. So we've got a few things to do. All right. Next up is Dr. Jared Klein, and I'm not sure if Kat Jones and Gigi Titini is here to talk about addiction medicine. Did you have a presentation, Jared, that you want to share?
Yeah, sure, Michelle. Thanks for having me. I have some slides if that's helpful to guide the discussion, but not mandatory if we just wanted to chat. But let me see if I can put these up just so we have something to look at while we go through. Thanks for having me. So I'm Jared Klein. I'm an addiction medicine doc and internist, and I work in adult medicine clinic, aftercare clinic, but also on the addiction consult service, along with Kat Jobs, one of the nurses who couldn't be here today. She had a conflict, and Gigi Tatini, one of the nurse practitioners. Actually, I think I saw Martin. I'm not sure if the Martin is Martin on the consult service, but he's another one of the APPs on the team. And we basically wanted to come and just let you guys know, since the addiction consult service is relatively new at Harborview, let you guys know a little bit about what we do and who are the team members. talk a little bit about some of the things that we think are important when caring for hospitalized patients with OUD specifically, opioid use disorder or OUD, and then mostly an opportunity to ask any questions that you guys might have or get your thoughts about how things are going with the consult service in the hospital. So let's see. So briefly, that we have a very interprofessional team. So in addition to the what says MDs, it's MDs and APPs on our team. But from a provider standpoint, we also have a nurse. We have 3 peers who are in long-term recovery themselves, some administrative support, and 2 social workers who are also substance use disorder professionals, or SUDPs. So depending on the patient's needs, whether they need recommendations on medication treatment, whether they need counseling around harm reduction strategies, whether they need kind of peer support, we have different team members that kind of offer different services to patients. And sometimes individuals might have multiple team members seeing them, or they might just be working with one person. So the way our workflow is at the present time, at least, is that when you contact, either put an Epic consult in for addiction medicine or call us through the paging operator, those messages go to the social worker, substance use disorder professionals, previously known as the expert clinicians, who do the triage process for us. So they might ask a few questions or review the patient's chart and decide which team member is the best person to start with it. If it's clearly a medication issue, then they'll have the docs see the patient. If it's a little bit less clear and the patient needs some additional substance use history, they might go and do some initial screenings or assessments and then figure out what the patient needs. So just so you know, you might not always reach like a provider on the initial call. If we're involved, if one of the docs or APPs is involved, then we'll kind of have a conversation about medication initiation, especially around Suboxone or methadone. And then often these patients follow up in aftercare clinic as their first stop and then referred on to community resources. If they're not local, then we might connect them directly to someone, a provider locally in their community. Throughout the whole process, the nurses or the peers will support folks if needed. So that's kind of the general workflow. And we definitely want to be available to folks. We try to sign into cores. You can page us through cores or send a secure chat, or lots of different ways to get a hold of us, hopefully. I think discharges for folks with substance use are particularly challenging sometimes. So just wanted to touch on the fact that we know they can be complex and difficult. For patients that are going to a skilled nursing facility, right now we're actively working on partnering with the bed readiness facilities to make methadone a more viable option for folks, especially going to those facilities. It remains challenging. We've been successful. We've been able to do that successfully a handful of times, but it is a challenge. Buprenorphine is okay for skilled nursing facilities. And in general, having somebody on medication is going to be better than an untreated substance use disorder. So we do encourage the use of medications for opioid use disorder. For patients going to respite, either medication, methadone, or buprenorphine would be fine. Buprenorphine, is Suboxone is the brand name of that. Either of those would be fine. The patients, especially if they're not already enrolled at an opioid treatment program or OTP, they do have to get to Evergreen for an intake appointment at least, but then their doses could be delivered to respite subsequently while they're at respite. Occasionally, a representative from Evergreen has come to the hospital or come to respite to do the intake, but it's kind of extraordinary circumstances for that. And then for somebody just discharging back to home, they could go to an opioid treatment program. Which is also a methadone clinic. but that needs to happen within 3 days of discharge. There's very strict rules around methadone dosing, and you guys are probably mostly familiar with this. We can't prescribe methadone for the treatment of addiction, and we can only have the patient return to the hospital up to 72 hours, up to 3 doses, 3 daily doses of methadone. That's like a special exemption in federal law that allows us to do that at the discharge pharmacy. Beyond that, they really need to be getting their methadone and opioid treatment program. Yeah, we've written a couple papers about the consult service over the last 2 or 3 years since it's been in, and we think it's going well, but we'd like the feedback from all of you about how you guys think it's going. This was a paper that a few of us wrote along with some students, kind of comparing the ability of us to engage and link patients with trauma versus no trauma with their Suboxone treatment. And it showed that we were just as successful with the patients that had trauma, which I think wasn't always intuitive. Like sometimes it's, these are patients where there's a lot of pain and it can be hard to get people started on Suboxone, but I think we're doing an okay job with that, kind of similar to patients that don't have trauma. And actually our rates of follow-up are actually similar to folks that are just presenting for treatment. When you look at their 30 and 60-day outcomes, we're not too far lower. Our retention rates in treatment aren't that much lower than folks that are actually presenting for treatment, which is remarkable because most of our patients come to the hospital not seeking treatment. They're here because they had an injury or an illness that brought them in. They didn't come for addiction treatment. So it's kind of a reachable moment. We think. The last couple things, I should have asked Michelle, how much time do I have? I know you guys have a lot of other agenda items, but.
You have plenty of time.
Okay. Just thinking about how the words that we use when we're talking about folks with addiction or documenting about them, I think that those are important. So, some of the things we recommend to do are to, of course, establish a rapport. Asking about past use might be less threatening, starting there versus asking about kind of what's happening in the moment. We also recommend usually asking about, less stigmatized substances first, like smoking or like tobacco and alcohol and marijuana first before you're going right to, heroin or cocaine or methamphetamine. So listening for the patient's story, I think it's important to anticipate guilt and shame and fear. Not that you kind of project that on the patient necessarily, but just be yourself prepared to hear about, hard things and hard emotions that are coming up for patients. And then similarly, listen for and reflect concerns about bias and stigma, which I find are pretty much universal in the folks that I have interactions with around their addiction. And that's true in society at large and in their interactions with the healthcare system in the past. And just recognizing that they come with a lot of prior experiences, many of which have been negative. So, and the don'ts or don't avoid talking about addiction. It's hard sometimes because it is a sensitive topic, but I think it's important to still address with folks. So often it's kind of wrapped up in why folks were admitted to the hospital. Not always, but often. And I wrote here, don't make assumptions. I mean, I think it's important to kind of prepare yourself and be prepared to hear about certain things, but everyone's experiences are individual, of course. I like sharing this one study, which is now almost 12 years old, but it shows just how important the words we use are for ourselves and for the patients we work with. So the authors did a randomized clinical trial or RCT with over 500 mental health professionals. These are folks that you think would be kind of in tune to these issues. And they randomly presented these 500 mental health professionals one of 2 vignettes. The first vignette said that the patient is a substance abuser and is attending a treatment program through the court. As part of the program, he's required to remain abstinent from alcohol and other drugs. He's been compliant with program requirements until 1 month ago, when he was found to have 2 positive urine toxicology screens, which revealed drug use. The patient's been a substance abuser for the past few years. He now awaits his appointment with the judge to determine his status. So half the participants read this and half read this second vignette, which is the exact same vignette, but they swapped out the term substance abuser with substance use disorder, which is the current kind of terminology. And then they asked all the participants, like, what should the judge do in this patient, in this situation of this patient who has these positive urine tox screens? And that, as you might imagine, that those shown the substance abuser term were significantly more likely to judge the person as deserving of blame and punishment compared to those shown the substance use disorder term. So it just, I think, goes to show that these words really matter when we're talking to each other, when we're talking to patients and families. I think trying to use the medically accurate terminology is really important, and it's sensed by the patients, and it's also, can impact the kind of the choices that we do and the thoughts that we kind of have. There have been many of these studies. This is another study that's a little more directly healthcare applicable, where they randomized internal medicine residents with a hypothetical vignette using more versus less stigmatizing language, and then asked the residents, like, how much pain medicine should this patient get in this situation? And you can see that the folks that read the stigmatizing vignette felt like the patient should get less pain medicine than the ones that read the vignette that included the neutral language. So it just shows, again, that I think these things are important for us to think about. And so with that in mind, I like to show this example, these concrete examples of less preferred and more preferred terminology to consider. And I say this with hopefully with some humility, in that, like, I'm not perfect all the time with these things, and no one can be. And I think it's just a matter of trying to be a little more mindful of them. And the other big caveat that I always say is that patients get to choose whatever language they find helpful for them, or whatever language they identify with. So this is not, this is kind of, shouldn't be that expected of patients, but I think of medical professionals and healthcare professionals, we should use the kind of less stigmatized, more neutral, or medically accurate terminology whenever possible. So yeah, instead of addict or user, it's like a person with an opioid use disorder, it's person first language. The second one is the old DSM-4 or diagnoses. We now use DSM-5, uses like the term blank use disorder, alcohol use disorder, opioid use disorder, et cetera. I think clean and dirty is pretty obviously problematic, and instead just saying like the urine test was positive or negative for X, I think that's more descriptive. Also, it's more helpful to know like what it was positive for, instead of it's just dirty, like what does that mean? So you could also say was expected or unexpected, something like that might be more neutral. Yeah, clean and sober, like in recovery versus using, I think would be an easy, quick way to say that. Relapse is hard for me because that's just very common and what I was trained to use for many years. But I think the idea behind using return to use is that it's a little less like all is lost, like back to square one. Like I think a lot of times relapse has that connotation of like everything is for naught. And we hope that with each treatment attempt, people learn more and about themselves and about, what things are helpful for them in their recovery. So treatment failure versus treatment attempt. And then the last one here, I think is really important, especially when we think about like methadone and Suboxone. Instead of using the terms like opioid replacement therapy or opioid substitution therapy, that kind of feeds into this mindset that we're just replacing one drug with another, which is already something that we have an uphill battle often with patients and families about. And really, I think kind of making sure we're talking about medications for substance use disorders or opioid use disorder in the same way that we talk about other medications. Like we don't usually think about, we talk about blood pressure medicines as like medication assisted blood pressure treatment, or like insulin as a replacement therapy. It's it's just a treatment, it's just a medication. So similarly, just calling these medications for opioid use disorder or medications, something like that, I think is better, especially when there's a lot of strong evidence that these medications are effective. They help people stay alive longer. They help people stay employed, prevent people from getting HIV and Hep C and all these other good outcomes. So yeah, that's a lot of me talking. I think that's all I really had, but would love to hear your guys' thoughts or questions, or if Gigi, if you're on, if you have anything else to add, or Martin.
Yeah, there's a couple things I've been asked these questions a couple times, just wanting to clarify for everyone. So for methadone for opioid use disorder is only in the liquid form, and that's what they receive at the methadone clinic. And that's just as far as reducing any risk of diversion. And so as an outpatient for opioid use disorder, they can only be dispensed methadone at a methadone clinic. So we're not writing prescriptions for patients with an opioid use disorder. They can only go to the clinic. And then also if a patient misses their dose at the methadone clinic, they wouldn't get dosed in the ED. They might be given a small amount of methadone just for withdrawal, but they're not going to be dosed at their normal dose.
Thanks, Gigi. That's great. Yeah.
So we should never refer someone to the ED if they've missed their dose, and or other than, well, I guess if they're having withdrawals, we would.
Yeah, they would be given maybe 10 milligrams of methadone and supportive medications for the withdrawal symptoms.
Most patients just should go back to their OTP, their methadone clinic, the next business day to get their usual dose.
So, can you guys explain a little bit more the relationship between ED consults, inpatient consults, and then outpatient consults? Do we ever? I've never called you guys from outpatient, so I'm curious if that's supposed to work at all.
That's a great question, Michelle. So I describe mostly the inpatient consult process. The ER process is mostly, Gigi, you could comment because I think sometimes you'll help support that process. It's mostly pretty protocolized around Suboxone initiations. There's an OCM that lays out kind of the clinical pathway for patients presenting the ED and wanting to start on Suboxone. And Gigi sometimes I think will support the providers there if they have questions or their nuances. Those patients will usually come to aftercare just like they would for any ER follow-up visit, although they tend to see Gigi when she's available. And for outpatient consults, we don't, there is, Harborview has a couple different places where folks can get addiction treatment. So the main two ways are there's kind of primary care-based addiction treatment. We call that OBOT, office-based opioid treatment. And we have nurses that see patients and they see their primary care doc for prescriptions and have visits pretty regularly. So that's one way of getting treatment. And then the Harborview Mental Health and Addictions Program has kind of specialty substance use disorder care where they would see an addiction psychiatrist and a counselor and have groups and maybe have medication treatment also. So I think they're basically just two different models of care, and there might be reasons that people, maybe people have poorly controlled mental health or psychiatric issues and would want to get their mental health and substance use care in the same place. But some other folks might have a lot of medical needs and want to be getting care in primary care and getting their Hep C treated and their wound care or whatever else is happening. Or they, some people don't want to go to a mental health. They feel stigmatized in one setting versus another. So I think there's a lot of, there's options, which is, I think, a good thing for patients. If somebody just needs a consult, I think that's the really tricky thing. If somebody has a question about a patient with a substance use disorder and needs a one-off consult, we don't have a super great mechanism for that. Right now, we do have some addiction medicine fellows that work in adult medicine clinic and kind of are probably the best option at Harborview to have somebody seen as like a one-time visit. Occasionally I've had them see folks that are like having surgery and like need a question around their medications for their substance use disorder perioperatively or something. So it comes up a lot, especially for opioid use disorder, I find, because like there's pain issues and there's the medications or OUD, and like it can get a little bit complicated. So yeah, I don't know, Gigi, if you have other thoughts about Michelle.
Yeah, so there's also an intake phone number where patients can self-refer. So that's the 744-2332. And so somebody's answering or returning calls Monday through Friday during business hours. So if a patient isn't ready, for treatment at this moment, you can always give them that phone number also where they can call and, self-refer.
And Gigi, you were going to mention something about the training.
Right. So they have done away with the requirement to do the X waiver training, the 24 hours for APPs. So there's providers can just, apply with SAMHSA just to get the X number waiver. So you no longer have to do the training.
Yeah, thanks, Gigi. There's been some confusion around that you still have to have an X number to prescribe Suboxone or buprenorphine, but you don't have to do the 24 hours of training for PAs and NPs, which is, I feel like for APPs is the most onerous. So it's the biggest benefit with this new rule change by doing away with that 24-hour training requirement. But you still have to go to the SAMHSA website and file a little bit of online paperwork, and it's pretty quick, and then you would get a new X license or a new DEA license that would have your regular DEA number and your X DEA number on that, and that would be required not for inpatient ordering of Suboxone, but for prescribing at discharge or outpatient prescribing of Suboxone.
And I had sent you that link, Michelle, as far as where to apply.
Right, I'll send it out with PowerPoint. Other questions?
I have one question. How difficult is it to get into the Harborview Mental Health and Addiction Clinic? Because I have had trouble when I've referred patients to mental health at Harborview in general, just saying that they don't have clinicians and they're not able to see the patients. Is it easier to get into addiction services versus other mental health services here?
Probably not a whole heck of a lot, unfortunately. I think some of this is probably pandemic effects, just the demand is really high for mental health and addiction resources right now. And so there's pretty long backlogs. And like everywhere, there's not enough, providers and staff to kind of support the need. So the other limitation to be aware of is that the Harborview Mental Health and Addiction Services only serves patients who reside in King County. That's my understanding. And so if somebody's outside of that geographic area, then that could be another limitation. That my understanding, the best way for folks to access, you can try to refer them and get them a scheduled appointment. There are also some, there's a intake and brief intervention service or something, IBIS, that sometimes can accommodate, maybe not walk-ins, but at least quicker access. I feel like the CCNs should know about that maybe, but I definitely empathize. It's a challenging issue right now. So on the primary care addictions, so I work in aftercare and in primary care, and we have pretty good access. We could usually see people. Aftercare we could see people same day or next day typically. And in primary care, it's usually within a week, maybe two at the latest. So
Probably one window that might be faster also is integrated medicine, which is within mental health, but just click integrated medicine might be faster because we do have slots for addictions.
That's great. Yeah, thanks, Martin, for that. Yeah.
Yeah.
Martin, you work in that. So there's some like integrated medical care in the mental health setting. There's also actually that when I described the OBOT, office-based opioid treatment, that same model is actually in the mental health and addictions program, but it operates like the primary care side. So there aren't the requirements for groups and counselor visits. It's a little lower barrier model. Than the kind of traditional intensive outpatient treatment that they also offer there. So yeah, lots of nuances.
Would that need to be a person that's already established in primary care here, or we could refer them for that reason?
Oh no, yeah, you can refer them for primary care with addiction treatment. That's totally fine.
I don't think they have to be primary care patients with us yet. I think they can establish through the integrated medicine, which is Martin Moore Rivera and Lucas McDonald, who do kind of a family practice / I think it's a health, the addiction medicine downstairs in the HMHAS department. Any other questions? Well, all right. Well, thank you for coming in and talking to us. That's great information. That was really helpful for us. I will send out the actual recording, so we'll send it out for people to watch later as well.
Sounds good. And I'm happy to send my slides along if that's helpful, Michelle. And thank you all for coming and for all your hard work, you know, in the hospital and the clinics in a busy time. So I know it's not always easy.
Great. Thank you. Are you guys seeing my slide?
Yes.
Okay, sorry. Well, I have the Windows 7 and it does not like Zoom at all. All right. So I will send out the video after as well. And I will send out Jared's PowerPoints because they were a lot of great information. And remember that we do have a roster with everyone's names, departments, and emails. If you ever have a question, if you go to our website and then there is like the roster with everybody, so you have access to that. Just some quick information. Let me go back again. Again, the compliance is a big deal. We got to get those done. And then it's been a while since I went to that last medical director meeting, but every time you go to the medical director meeting, there's a lot of information given out. And they always go over the financials. I don't always completely understand, other than this last year, they made a comment that, you know, everyone has noticed how full we've been. We feel very full anyway. But what the issue is that we've had longer lengths of stays, but less patients. So that does affect kind of the billing for that, because there are kind of maximums that we get paid out. And so I think labor has been a big issue this last year because travelers cost more money, and we've had a lot of travelers throughout the hospital. Hospital very willing to hire them because we need them, but it does affect the bottom line. But it sounds like we were actually off to a good start in the beginning of the year. Just kind of a continued update on the bond. As you know, the bond was approved last year, but this is a 10-year process. So it's going to be a while before it comes to fruition, right? I think one of the biggest things that I didn't realize is that, yes, the bond covers the building, but when we expand, like respite is going from 38 beds to I think 125, we have to figure out how to staff that, and that's not paid by the bond. So a lot to go that's going to go into this process. They hired a firm. I know the first step has been done. They've hired a firm who's had a lot of history with expansions. And so the consultant's going to be on board and kind of starting this process. And the biggest issues that we've had are length of stay in medicine. Surgical services have been doing pretty good with that. The mailing expansion, this is a 2-year project. It's going to add 40 more beds. And one of the comments that comes up in the medical director meeting and multiple meetings in the past was, why did we not increase our bed number? But we have a lot of beds here at Harborview that are 2 beds, I think even sometimes 3 beds. But the problem is if someone has to be quarantined or isolated, you lose that whole room. So you've lost the other beds. The mailing expansion will be single room beds, single bed rooms. And so that's going to add 40 more beds and in the shorter term before that bond gets done. And I know they've reached out to a lot of the department heads to figure out how that's going to happen. I'm not sure if you've heard this before, but mailing, there's 2 floors on mailing that are clinics. All those clinics are being moved over to 9th and Jefferson, and those floors had previously been IT, have already been emptied, and so there's going to be this transition that happens in the next probably year. We'll keep you updated because that's going to affect a lot of you that work on those floors. Just the final vaccine update that we're getting down to the time, to the crunch that you need to be vaccinated or get your information in to receive saying that you don't need to get it or that you've been approved to not get it. Sorry, I can't think of the word today. And so far it is 16 plus for Pfizer, and they're still looking at going to the younger ages. I've heard some rumors that they're actually some places are actually already doing, in other countries are doing it as low as 2-year-olds. So that's going to be interesting to see. And so here's a timeline again. If you haven't received your vaccine, what options you have at this point. I don't think they've approved boosters yet. I think it's coming down the pike. They're expected probably the next couple of weeks to determine whether boosters are going to happen. At the last medical director meeting, Kelly was asked to give kind of reflections on this last year and the surge with the pandemic. I'm curious some of your thoughts. Anyone have anything to share? What we've learned, what we'd like to think we should be doing differently, anything.
You'd have to give me a cold beer to talk about that.
Well, yeah, I don't normally drink a lot, but I've had a few margaritas in the last year. Yeah, I think it's something to think about. I'd love to eventually have a good conversation. It's been a tiring year, more than a year now, right? A lot of burnout. We're seeing it nationally. It's not just here. And lots of opportunities for trying to figure out that balance, right? I think there's been a lot more thought process on what's important in life with all this. And on that note, we will give one last shout out to this. This is Grand Rounds is coming up on October 14th. You can register with that link, talking about burnout, basically. And you can see how there's a lot of people kind of that disengagement and very reasonable reasons, right? Like, there's just been a lot with this. And at the same time, Harborview is kind of growing. We've seen, I think, since Jenny and I took these roles, I think we've hired 30 or 40 new people. We've expanded, and there's been 3 new services on inpatient. Outpatient has expanded in a couple of departments as well. Lots of work, which is great, but also I think changing in our roles has happened as well. So a lot going on. We're actually going to get some free time back if anyone has doesn't have any comments or have comments. Sorry, well, running around. But questions, comments?
I wanted to say something about telemedicine.
Oh, go ahead. That's right.
Yeah. Hey, everyone, this is Charles Wiley with the Burn Service. I just wanted to reach out to other APPs at Harborview to connect with me, just with my work email. I'd like to hear more about who's doing telemedicines, how they're going, problems, and what has worked for you to and how it's impacted your practice. So it's I'd like to come down eventually and find out some of the different telemedicine offices we have and what sort of hardware you're working off of and what sort of office space you're allocated. So at your convenience, it's I am at CAWiley@uw.edu. That's all.
That would be great to get feedback. I know quite a few departments really transitioned to telemedicine right off from the beginning. And so, and you're doing it differently. Like some people are doing blocks, some people are doing it in, mixed in with their regular appointments. What's working? What have you changed that wasn't working and now working? And I think I sent out an email because I didn't know the answer to this, and it made sense when someone told me. But prescriptions, people are asking about writing out-of-state prescriptions, and I was like, I know every state's different, but it sounds like if you prescribe to like Costco or Walgreens, places that are in multiple states, they can get it filled in those states off of your prescription from the Costco here, without you actually using your license for another state. So that was great to hear. And if, again, these are great things to hear from people. And so again, I think Charles has a great idea of kind of getting a little bit of a work group together and kind of seeing what have you guys been doing, what's worked, what's not worked. I know some departments have multiple, like Charles has licenses in multiple states because they do a lot of telemedicine. They were doing it before the pandemic. And now a lot of us are still continuing our departments post kind of craziness, although it's still kind of busy, doing a lot of telemedicine work, and it doesn't seem like it's going to go away. And I'm just love to hear that feedback. All right, guys, it's about 12:44. And so again, I will send this out with the PowerPoint, and I will get Jared Klein's PowerPoint as well. And we'll get those things out to you. And we'll see you at the next brown bag. Bye, guys.